you. So I'll have Jodh speak next, and he's all the way from Singapore, one of the most prolific speakers, and he's been doing Lenticule for more than 10 years, as I understand, and has done amazing amount of work. He's speaking on optimization of your Lenticule for Klex, a very interesting topic.
Thank you, Prof. Thank you for the invitation to partake in the course as well. Okay, so I'm going to be talking about optimization of Lenticule for Klex surgery. So when we look at Klex in 2025, of course, we have many machines now that are available in order to do this procedure. DICE basically have the new VisuMax 800, Schwind have the AIOS, Zima have the Z8 with the clear procedure, and J&J have the Elite procedure that produces silk. And you see from this table over here, there are many differences, or there are many subtle differences amongst the machines itself. But today I'm going to really just focus on one of these, and this is basically the lenticule shape. And what you'll see is that most of the machines will generate a lenticule that is basically planar convex in shape, but the Elite system generates a basically biconvex lenticule. If you look at this from the schematic, you can just basically see this in detail with respect to the lenticule shapes that are basically created. On the left-hand side, the biconvex shape with the Elite. On the right-hand side, really pretty much most of the other companies make some kind of concept shape with this, but they're not all quite similar with respect to their planar convex curvature. If you look at the lenticules that are created, and this is done in a human donor eye bank study, and then you do OCT, you will see actually when we compare the Zima on the left-hand side compared to the VisuMax on the right-hand side and do OCT sections and then measure the thickness, there is a difference in the actual lenticule shape configuration between the two machines. Typically what you can see is that the side cut on the VisuMax is between 15 and 13 microns. This is typically, this is a 15 micron one on this side over here. But the lenticule shape in the Zima, for example, goes down to a side cut angle of basically 0. And that's why you get this difference in this diagram below over here in this figure, where you can see there is a slight difference in the shape, even though it's overall a planar convex shape, but there is subtle differences within the lenticule configuration itself. So when we consider lenticule creation, there are really variables that you need to basically think about. One is the cap depth. Second is optical zone, obviously the incision size, the side cut, and the centration of the lenticule itself. This is just looking at the lenticule formation. I'm not going to talk about energy optimization and nomogram adjustment, that's a whole separate area itself. But presuming you've got already your energy adjusted and the nomogram is basically adjusted as well, you still have these variables for where you see every patient itself. And over the next couple of slides, I'll show you how you can work out what's the best way of basically programming the laser in order to get the best outcome for your patients. So let's take this one by one. Let's look at incision size. Why do we always go for basically a small incision? So really this is going to be dependent on your experience basically in lenticule procedures itself. If you've done a lot of lenticule procedures, I would never start off with a small incision, maybe start off with a 3 or 4 millimeter incision itself. But as you get more experience, I'll try to reduce that incision size down, and typically, routinely I use basically 2.1 millimeter as my standard incision itself. Why do we do that small incision? This paper from basically John Marshall, now published over a decade ago, basically looked at the effect of basically making a lamellar cut or a vertical incision side cut. And what you can see from over here is that the weakness in the cornea itself comes basically from that vertical incision cut, not from basically the lamellar cut in the corneal stroma. So however big your basically vertical incision is, whatever in size you make your incision size itself, that's what's going to basically contribute to the biomechanical weakness of the cornea itself. So the smaller, basically the better itself, okay? If you make 2, even if you don't open 1, as soon as you've broken through Bowman's membrane, you're going to basically weaken the cornea itself, okay? So ideally try to go, when you get more experience, keep on dropping the side cut angle down, basically try to open it to only 2 millimeters. What about basically optical zone measurements? Now, when we program the laser, this is basically what the optical zone that the surgeon is basically programming. Okay, when you look at the effect of the biomechanics on the cornea itself, this is what we call basically functional optical zone, and that's related to the biomechanical response. What we know from this study from Dan Reinstein basically showed us is that if you look at this increasing size of basically the optical zone of patients from 6.5 to 7, you're going to basically get an increase in the amount of spherical aberration induction. Okay? So what that means is for the same dioptric treatment, if you basically have a smaller optical zone, you're going to get basically more basically spherical aberration. Right? If you can basically increase your optical zone, you can basically cut this down. Of course, the downside of increasing the optical zone is that you're going to eat more tissue up to basically do the ablation treatment. So you need to basically take this in consideration of other parameters. So how does this relate to centration? Okay, well the way you can link your optical zone to centration is that if you decenter the lenticule by more than about 335 microns away from the centration point, again you're going to basically, from the corneal vertex, you're going to introduce spherical aberration induction, and that's why your centration has to be as close as possible onto the basically corneal vertex to reduce the induction of spherical aberration. So you have two parameters, centration and optical zone size itself, and I'll show you how you can apply this clinically in the clinical examples I will show you. If you basically decenter the eyes, and this is basically the group 2 over here with the open circles itself, not only will you induce high order aberrations, you will induce basically vertical coma, spherical aberration, and you will also basically induce, there's a chance of inducing horizontal coma itself. And this is related to decentration irrespective of the optical zone that you will use. So decentration alone will have a higher induction of basically all your aberrations in the cornea. If you look at this as in relation to optical zone size, even though the correlation coefficients are actually not that high, they are statistically significant. And what it tells you is that, again, decentration is relative to basically optical zone. So if you have something that is basically a pupil or an angle kappa that is more decentered, a way of negating this is by increasing your zone size. Okay, and this will help you get around those difficult situations. The fifth thing to look at is basically cap depth. Okay, why do we want to go basically deeper? Remember, you're going to do a smaller incision, so you're going to reduce the biomechanical effects. If you go deeper into the cornea, you're going to be able to get a faster recovery of the ocular surface itself. And typically, on a routine case, I'll go 130 microns basically depth. This will increase the speed of recovery on the ocular surface. However, you need to balance this with respect to the RSB, okay? And of course, if you go deeper than basically 130, like 140 or 150, you will definitely need to do a nomogram adjustment, because the deeper you go into the cornea itself with an infrared beam, you need to basically do an adjustment of the amount of stromal tissue you're basically going to remove, because you're going to basically go deeper to remove the posterior cut as well. For shallow anterior caps, which is often what we have to compromise on and use basically in patients with moderate to higher degrees of myopia, obviously you have a higher risk of getting a cap edge tear because your cap is basically only 100 microns thickness. Okay, so these are the basic principles to think about when you're basically thinking about how you're going to program the lenticule on every single patient. And then I'm just going to basically show you some examples of basically how we do this. So let's just take this patient to start with. She's a 27-year-old male gentleman. Anterior posterior segment is normal. Basically does sports, the investigation officer in the police. If you look at the refractive error over here, it's low myope, minus 350, a little bit of astigmatism, very good vision, 64.5. If we look at the tomography readings over here above, you can see pretty much normal tomography. The Corvus data down below over here shows basically normal TBI and normal BADD readings as well. If we look at the left eye, again, very similar kind of pattern, a bit more astigmatism on this side, but basically normal biomechanics on basically the TBI side as well. If we look at basically the angle kappa, what you can see is that the kappa intercept is larger on the right eye and absolutely dead straight in the left eye. So what does this tell you? So this tells you that basically I'm a little bit concerned about the larger angle kappa on the right side. It's not too large, because I can tell by the readings over here it's only 0.4 on the intercept itself. But whatever I do, my optical zone is going to be larger on the right compared to what I can do on the left. Now, the corneal thickness in this patient is quite good. It's around about basically 540, so I can be a little bit liberal, and actually I can do a large optical zone basically on both sides. And that's exactly basically what we did. So what we did in this situation, this is when I used the 800 Vigimax laser. I did 130 micron cap on the surface, because that gives me the optimal ocular surface recovery. I don't need to worry about RSV in this example, and I basically did a treatment with a 6.7 millimeter optical zone basically in both sides. This is with my nomogram adjustment and with basically the energy optimized on the laser. This is the 1 week visual acuity result. Okay, so you got a good visual acuity result. I don't need to worry about the angle kappa on this side, because I increase the optical zone basically to 6.7. Let's look at another case. Okay, 26-year-old guy, again, very similar age group, but this time you look at a very high myopia, right? Minus 9.75, this is very common to what we see in Singapore, with a bit of basic astigmatism, minus 850 on the left-hand side. Let's have a look at the tomography. So tomography based on the right eye essentially looks pretty normal. The Corvus data below over here also basically looks pretty normal. Corneal thickness around about basically 560. So kind of like borderline really on how we're going to basically push this limit. So you know already we're going to have to do some adjustment on parameters in order to basically get this guy to be able to do a lenticle extraction basically procedure. If we look at the left eye, again, very similar basically pattern over here. BADD looks quite normal, and your TBI, basically biomechanics, also looks normal as well. But because he's a high myop, I automatically know his corneal incision size is going to basically be 2.1 millimeters as well. Let's look at the angle kappa. Now the angle kappa over here, you can see, or the kappa intercept on both the scans over here, on both sides, slightly more deviant on the right eye compared to basically the left eye over here. So you can see this on this side over here. So what it tells me is that I need to adjust the angle kappa to make sure I get a basically good refractive result. But of course I cannot go too big here now because this is a high myopic treatment, so I need to basically do the high myopic treatment. So I need to compromise on something here in order to basically do the treatment. So what do we basically do? So what we did was that we use a 100 micron cap. So I basically tried to give myself the maximum level of basically myopic correction. Because the angle kappa was slightly superior over here in the left eye, I wanted to make sure I incorporated this into basically my optical zone. So I use a 6.3 optical zone treatment on the left-hand side. On the right eye, I use a 6.0 optical zone because I thought I can get this absolutely bang-on centered because the angle kappa was closer to centration on the right eye compared to what I could see on the left eye itself. Okay, and I compromised a little bit on the left-hand side. And also remember, you have to make sure you have enough RSP. So I had over basically 300 microns RSP on both sides on the right and basically slightly less on the left side because I increased the optical zone on that side to incorporate the deviation in the angle kappa because it's slightly more superior, and with the 500 lasers it's a lot more difficult basically to do the centration compared to basically the 800. Okay, so this is your compromise that you need to think about when you're doing the programming. So when we see basically the outcome, so one day outcome pretty good, 7.5 plus, this 9.4. When we basically see them at 1 month, so pretty good now. The visual acuity is basically picked up from both sides. But remember, because it's a high myope, you have to treat the ocular surface very aggressively because I've compromised on the fact that I want to do a laser vision correction treatment when they're with a laser. So I know as a high myopia, I'm going to basically induce more dry eyes because I've compromised the cap to basically go to 100. So you aggressively have to treat them with ocular surface with cyclosporine, topical eye drops, and basically give them plugs and omega-3, basically flaxseed oil capsules as well, in order to basically pick up the surface recovery because you know they're going to have delayed recovery because I've compromised a little bit with my lenticle size by having a 100 micron cap there itself. So you can tell them that straight away this patient will have an immediate plug put in at 1 week to basically help them with the ocular surface recovery. So in conclusion, successful lenticle requires optimization of many parameters. Okay, it's not just the energy. Obviously, you need to think about your nomogram adjustment, but when you're thinking about the lenticle itself, the parameters are basically listed over here. Your cap depth, your incision size, your optical zone, and your centration, and your cycloid side are going to basically affect the outcome. And you need to tailor this for every individual patient that you will see itself. My default would always be 130 microns at 6.7, but I vary that depending on pupil size, depending on many of these parameters that I basically showed you as examples basically today as well, and to basically achieve the best outcome for the individual patients. So you do need to customize yourself, and this is an addition to the customization of nomogram adjustment, and obviously the idea is by doing this you can improve your short and your long-term outcomes.